Okay, today is the second part of endocrine. It doesn't have anything to do with diabetes except diabetes insipidus. That ain't got nothing to do with your sugar. So, we're going to start out with this because ADH, what does that stand for? Anti. It's going to keep you from big. Alright, so ADH works where? In the kidneys. What does it do? So if let's say that I went out and ran the marathon, I wish, what is my body going to do when my blood pressure starts dropping? Hey, what I need to do? It's going to release ADH. You're going to go to the kidneys, so they concentrate that urine and hold on to the water. What does it do to my blood pressure? Increases, right? What if that system goes haywire and it says I'm going to keep all the water? What's going to happen? Ascites, edema. What's ascites and edema in the lungs? Pulmonary edema. In the grand scheme of things, all of these represent what as far as your volume status? Hypervolemic. You have got way too much water. Now, the urine that they are producing, if I have too much, is what? I already said it. It's concentrated, very concentrated, and very little anti-diuretic. You ain't peeing. Because when we give somebody Lasix, I want them to what? I want them to pee. So more causes fluid retention. What is less? There ain't no anti in the anti-diuretic. All it is diuretic. What's going to happen? They going to pee. We have to talk about this. And guys, don't get in the weeds about this. This is not that difficult. Osmolality. Did I say osmolarity? No, I did not. Osmolality is a concentration of solutes in body fluid. What does that mean? Is in your body fluids a lot more stuff and a lot less fluid, right? So if I had diabetes insipidus, how much stuff is in my body fluids? Diabetes insipidus causes you what? Pee bad. What's inside my body? A lot of stuff. Hypernatremia. What is their osmolality going to be? High. Now, let's go SIADH. Their osmolality is going to be what? Low. Don't get these confused. Urine specific gravity. All this is this only for urine. Right? So with SIADH, you're soaked inside. How much volume do you have in here? A lot. So your stuff is watered down, right? And we said they're making concentrated urine. How much stuff is in your urine? A lot. So your urine specific gravity in that is going to be high. Now, in diabetes insipidus, we're making, I don't remember how much is the top level of a Foley bag, but I told you guys that patient in the trauma ICU, we didn't know that he had diabetes insipidus. He had a traumatic brain injury. I walked out and I walked back in and the Foley had burst. Is it a liter? I don't know. It's like 1,500. Guys, that took me like 5 minutes. So, they're losing that much volume. What is their urine specific gravity going to be? Low. All it is water. Where's all your stuff? In here. So your osmolality is going to be high. Guys, it's all about the stuff. We're all about the Joneses. We want some stuff. If you are diluted inside, you ain't got no stuff. It's coming out. These are specific. You can just put in the blood right here. Because what kind of test is that? Blood test. diuretic part. How much urine? A lot. And how much is left inside? You also have a lot of stuff. What electrolyte are we worried about? Sodium. If all the stuff is inside and you just told me sodium, what are we worried about? Hypernatremia. And what? Why are they hypovolemic? They're peeing everything off. This is kind of like if you had a patient that came in when we were talking about non-hemorrhagic hypovolemic shock, and they've had diarrhea for the last 7 days. It's no different. They just lost it really quick. That's even worse. So what is their blood pressure going to be? What's that CMP going to show? Your sodium is going to be through the roof. What does that electrolyte have? What effect does it have in the body? Your brain? If it's too high, what are you going to see? Guys, in any of these, that's the first key thing. If your sodium's too low, if it's too high, you're going to have an altered mental status. That's going to happen. If they got all this stuff inside, what effect is that going to have on them? So if you're dehydrated, what do you want? Water. They're going to be asking for water every 5 seconds. Is this somebody that you're really going to regulate how much they drink? No. Now, can they refill their tank just by drinking water?
No.
No, not at this point. If we get it regulated, maybe, but not right now. So what are we going to have to do? You got to give them an IV. What causes it? I already told you one thing. So traumatic brain injuries, car wrecks, our soldiers that are in war and they have the explosions, an explosion period. If you've had surgery and you've done something to the pituitary gland, pituitary tumor, what is this? Meningitis. So this affects what? That. So how would you treat that? Antibiotics. Immediately. Nephrogenic. There's something wrong where? In the kidneys. What if you got a dialysis patient? How good are their kidneys working? So how much of this do you think they have in their system? How are these patients going to look? We've already said one thing. Dehydrated. How does dehydrated look? You're hypovolemic, right? If we go and I say your blood pressure is 80/40, they're now in hypovolemic shock. How does it look? Tachycardia, tachypnea. In this case, cool, clammy skin. What else? Talking about skin. Skin turgor. What does that mean? You pull up on it and what? It makes a little tint, and if it stays, that's bad. If it snaps back, then your volume status is pretty good. Now, is that the end all be all? It's not. As we age, it gets worse anyway. Y'all don't get old. Everything starts to suck. I'm just saying. Remember why I told you they call this diabetes? What are the 3 hallmark signs of DKA? Polyuria, polydipsia, polyphagia, which means what? Peeing a lot, thirsty a lot, eating a lot, right? We already said polyuria. All of their volume is going out. Low specific gravity. Hyperosmolality. All the stuff is inside, right? Hypernatremia. Dry skin. It's going to tint. How else can you tell if somebody's bad dehydrated? Get them to open their mouth. I mean, know we got a whole bunch of mucous membranes, but you ain't gonna, I hope you ain't gonna see no more of them looking for dehydration. Y'all don't do that. Get them to open their mouth. There's something else that you can tell by getting somebody to open their mouth. You can look for blood. Why would it? You're right where I want you to be. If it's pale, what is it? Y'all ever watch Dr. Pol? I love Dr. Pol. He always looks at their gums. Why? Don't nobody in here watch Dr. Pol? Y'all fired. It's a vet show. And he always wants to see the dog, cats, guinea pigs, snakes, mucous membranes. Why? If it's pale, they're losing blood. What other color? Jaundice. Cyanosis. In dark-skinned individuals, can you see purple fingertips? No, you can't. You can't see it around their lips either. If you have somebody who is very dark-skinned, either African-American, I always mispronounce this, Arabic, anybody from over in that area, I mean, I've even seen people that were Hispanic that were so dark, you're not going to see this. Get them to open their mouth. Everybody's mouth is pink inside, right? Get them to open their mouth. What else is their mouth going to look like?
Cracked.
The Sahara Desert. No, really, your tongue will start to what? Crack and fit. Now, guys, that's bad. In an infant, what's the best way to figure this out? Fontanelle. Guys, if y'all put your little piggies on that baby's head and it goes like this and it's not a traumatic brain injury, that child is in trouble. Also, one more thing, if you feel this, they're not going to be what? Making. Who said it? Somebody said it. Huh?
Noise.
No. No, they're going to be very lethargic. They're just going to be laying there. When you get sad, you cry. They won't make tears. And like I'm talking to, guys, this is bad. And even an adult, if you are that dry, you won't see tears. And where you usually should be seeing like crocodile tears or ugly crying. And of course, all that salt and peeing up all that stuff, you are dehydrated. You're hypovolemic, and it leads to hypotension. What's your cardiac output? Is hypo too. Hypocardiac output. There we go. Y'all, here's my squirrel moment. I listened to this blog this weekend. Who in here had problems with trying to figure out defibrillation, synchronized cardioversion, and pacing? Y'all can raise your hand. So, if somebody told, and y'all ain't got to raise your hands for this, but y'all need to go back and talk to your clinical instructor, said you don't defibrillate anybody without a pulse. Yeah, that's what I was like. So, we defibrillate dead people. I mean, because the only thing we defibrillate don't have a pulse, right? Synchronized cardiovert. Conscious. And if it's too slow, you pick up the pace. Does that make it easier? I was like, that is freaking brilliant. The only thing you defib are pulseless VTAC and pulseless VFib. If they in atrial fib, I don't care. If they looking at you and they're conscious, you're not going to defibrillate it. So what are your interventions going to be? They don't get up. What's going to happen if they get up real quick? They're going to pass out. Why? Orthostatic hypotension. Guys, they will hit the floor. Is that a safety issue? Yeah. Sure is. Full set of vital signs. Looking at what? Real close. central line in, and they put in a CVP monitor, which tells me my fluid status, which tells me my preload. Y'all remember that? It was all hemodynamics. Make sure they're not trending in the wrong direction. Hypotension, tachycardia, they're going into shock. You need to look at their urine. If it's the color of her cup and it's white and clear, that's bad. If it's the color of her shirt and is that yellow and concentrated, that's bad too. What's this? After we get them out of the critical stage, what are we going to start doing for diabetes insipidus? You got to up the what? How much they're drinking. Now, this is not during the emergent phase because you can't get enough fluid in. How are we going to maintain their fluid intake? Through an IV. What kind? Large bore. Big as you can get it in this case. So, what's considered large bore? 18 and above. What color is an 18 gauge? Green. How about 16?
Gray.
Gray. 14?
Orange.
It's like a weird orangish looking color. What's pink? 20. Blue. Yellow.
24.
Where's my NICU people? Where's my NICU people? Who wants to work in the NICU? This is the only place I've ever seen it. It's a 26 gauge and it is the size of your hair. I was like, I ain't doing that. I've never seen it outside the NICU. It wouldn't be any good in an adult, right? What is this? I don't want them to fall down and go boom and create even further problems. Why am I going to weigh them daily? What's one weight worth? It's worth what one blood pressure is worth. Absolutely nothing. I need what? Did I push blood?
Okay.
I need trends. Guys, I can, damn, I got a headache. And you take my blood pressure and you're like, ooh, girl, it's high. Does that mean I got high blood pressure? Nope, ma'am.
I have a question, this might be dumb, but for the safe environment, would you be monitoring like seizures since there is like, it is hypernatremia?
You already said it affects the central nervous system, right? And muscles. What are you going to do for the seizures? Guys, patting the bed rail is huge. They're probably going to bite their tongue. Now what's the safety issue? Bleeding in there. What's their level of consciousness usually coming out of this? They either want to fight or they're either halfway unconscious. If they're halfway unconscious, what kind of respirations are you going to hear? Snoring, gurgling. They got blood in their airway. When patients are post-ictal, what do they say do even if you're not in the hospital? Turn them on their side so the blood runs out if they bit their tongue. Guys, any injury in that mouth is like a scalp injury. It bleeds so bad. Pad the bed rails, and then they put a pad on the floor in case one don't catch them. Hopefully the other one will. What band did y'all say? No, I'm talking about for the seizures. Sorry. Midazolam. What's the other two? We don't give them that much now. You gotta say the other name. Diazepam, which is what? Valium. Lorazepam, which is what? Ativan. Now guys, that is just during the emergent phase. But if they're not a seizure patient, are we gonna go on to Keppra? No! How are we gonna fix this? You've got to fix the problem. They just gonna keep seizing if you don't do any. Oh, look, they're having another one. Let's give them some more Versed. Yeah, you can do that as all you want to. They're gonna stop breathing sooner or later. Now we're gonna be intubating. Treat the problem. If they're in hypovolemic shock, volume. I'm not gonna give them blood. No, they don't need blood. Everything in your world, you need to treat the problem. Septic shock, antibiotics. Hypovolemic shock, fluid, neurogenic shock. You're going to start fluids. What else? You've got to give them a vasopressor, and you might need to give them what kind of medication that we gave in the advanced, atropine. That heart rate's what? 40. And you might have to think about what? Picking up the pace. You might have to pace them. Is their heart the problem? It's not. I'm going to do the CMP. Now, what labs do we do for dehydration? CMP, what else? CBC. What do you get on a CBC? White blood cells, platelets. So, CBC, right? The H, white blood cells, what goes over here? Platelets. Which of these is affected by dehydration? What happens to the, guys, what is this? It's stuff. Hemoglobin and hematocrit. If you are losing volume, it's going to, now, not bleeding. That don't count for bleeding. If you're bleeding, what's it going to be? Low. Any other case with dehydration, how much stuff is left in here? You either sweated it out, peed it out, pooped it out, something. Your hemoglobin and hematocrit is going up. You still got more stuff. This is not, we're not really speaking about diabetes insipidus. It's going to do the same thing. They're not bleeding. That's not the problem. They're losing so much fluid, they are dehydrated and going into hypovolemic shock. You still look at the same markers. What about your CMP? What am I looking at for dehydration? Huh? Sodium? Potassium? Chloride. This is what I want to, this, and something that goes right here. This is glucose, BUN, and creatinine. What happens when you are dehydrated? They go up. If you have hypovolemic shock, what comes next? If you don't address it. Mods? Which organ system is affected? Your kidneys. So your BUN and creatinine is going to go up. Sooner or later, you're going to have what? Kidney failure. These are your dehydration labs. BUN creatinine, I definitely want to look at my salt, hemoglobin and hematocrit. We're not talking about bleeding. We're just talking about volume. Their blood osmolality is what? Where the stuff? It's inside, so it is high. Concentrated solute in the blood. Urine specific gravity. It's low. This is the stuff in your urine. You're peeing 3 liters a day. Dilute or concentrated? Diluted. You ain't got no stuff. So your urine specific gravity is low. Guys, the only reason I'm telling you about this is when we start dealing with this, you're going to see those tests. I need to look back. Yes, it's a case scenario. It gives you signs and symptoms, and it will either give you high and low, low and high, or not affected. So you have to look at the big picture and figure all of it out to tell you what you have and maybe what you need to do first. You don't have to memorize the numbers. I want you to know if it's high or low. Guys, y'all know me by now. I'm telling you, at ARDS, I gave a shit about. I don't give a shit about them numbers. You can look at somebody, you walk in like, oh, they're sick. What's your general impression? Sick, not sick? You go over there and their skin takes up. Even if you don't know what's going on, you ain't seen the Foley bag burst, you open their mouth and at that point, this is a pathophysiology for what? Dehydration. Then you treat the cause. How do we treat it? They don't have what? They don't have vasopressin, so we're going to give them what? Have y'all heard that med? Where? Vasopressin. When do we give it? Shock. Who wants to work in the ICU? MI, trauma? Not really trauma, but sometimes. You're going to see vasopressin. A lot of times it is a second line pressor. Guess how it works? It increases your volume, right? That's how it elevates your blood pressure. IV fluids, 3% saline? No, they don't need no more stuff. You might actually give them what? Huh? Hypotonic. Why am I giving them hypotonic? How much stuff is in that bag of fluid? Not a lot. How much stuff is in 3% saline? A ton. I'm not saying it will be hypotonic, but at the minimum, which one are you going to start out with? Huh? What's the other word for it? Isotonic. Iso perfect. Is exactly middle of the line homeostasis. Hypo is not enough. Hyper is what? Too much. You would. So if I got all this stuff and I give you like water that ain't got no stuff, where's that water gonna go? Into the vasculature, which is where I want it. If I have all this volume and no stuff, which one am I going to give you now? Hypertonic. What does that do? It draws that water out. Now I know you're going to say, Miss Thornton. For SIADH, they're volume overloaded, right? Their sodium is. In this case, that's more to treat that. Isotonic is what? 0.9, right? I also called it hypertonic, but I also called it something else. Guys, I'm not going to give you a question that you have to decide between the two. You would either go to isotonic or hypotonic. The isotonic is something we run and grab. The hypotonic is something that the physician probably needs to order. Guys, I'm not going to give you that. I wouldn't do that to you. It's either or, depending on, honestly, it's probably depending on how bad it is. So you said what? 0.9%, right? What's this? Half normal saline. All right. What's this? Hyper. 0.93. This ain't got a lot of ones in it, right? I ain't even up to the 1. Do you see why this is hypertonic? That's a lot. What kind of medication is this? Huh? Why is it a high alert? How are you going to hurt somebody? What if you gave this to a DI patient and their sodium is 160? They're going to die. Right? So, if it's a high alert med, what are other high alert meds? Insulin. It's given IV most times if they're this bad. Heparin. It's an electrolyte. Potassium. 3% saline. What color do you think the label is? Red. What color is potassium? Y'all probably have seen it by now. Red. Anything red and yellow needs to get your attention. Red, yellow, and orange. If we're going down and crashing, it's not blinking a green light. Right? Everybody can be like, oh, it's fine. did that. And we used to give 3% on the helicopter, and they would have it the IV bag, and it's not big, inside 2 biohazard bags. Why? You got 3 chances to figure out, I might need to look at this. Do you think? Why do we come up with rules? Because somebody did some stupid stuff and gave 3% when they didn't need to, and everybody's like, ooh, this is risky. Instead of 10 units, you gave somebody 100 units of heparin. High alert medication. This is why you have to have 2 nurses sign on. You got 2 chances, 3 chances if you scanned everything right to figure out you're going to make a mistake. When they get home, guys, this doesn't go away. It don't just, poof, there you go, you're fixed. Get out. You're gonna have to tell them what? You can't eat all that salt. Basically, they tell them to keep water with them at all times. And they need to have what on? A medical alert, because if they have diabetes insipidus and somebody just runs up on in their season, what are they going to think? Ooh, it's the seizure patient. If you have diabetes insipidus, okay, they're having a seizure, I need to monitor airway, but the second I get to the hospital, what's my priority? Huh? Fluids. I want to know what? I want to know their sodium level. I need to know how bad this is. So do you see how your priorities will shift? If it's just a seizure patient, and I know that's bad, what's my priority? And this is too. They're seasoned. What's my priority? Airway, breathing, safety. Guys, and I'll talk about that in the class. Safety is always in there. Safety is huge on the NCLEX. Because with safety of pharmacology, we suck. Giving the right dose, giving the right med at the right time. The area that is the lowest scored besides P's is pharmacology and safety. So, I didn't have enough, so I was peeing everywhere. Now what? I got too much. Because this is the #1 cause of SIADH. I think that's important. Here again, though, what? It can be traumatic brain injury. It gets everything messed up. It can either secrete way too much or way too little, right? How hard do you think sepsis of the brain is to treat? Very, why? Not all beds cross the, and I always have trouble saying that. Say that 5 times real quick. Blood-brain barrier. Very few antibiotics actually cross it. And heaven forbid it's a fungal infection. How are they going to present? How are they going to look? Swollen? They got these swollen on. How else? Edema. Huh? Wet cough. What are all these signs and symptoms of? Not even that. Fluid overload. What are you going to hear when you listen? Crack. And then, guys, it's going to be bad. If they have come in and they're not going to know they have this, or they wouldn't be in the emergency room unless it's gotten bad at home. They're going to come in. What's their blood pressure? It's going to be through the roof. Be careful. Their cardiac output is great, right? Is it really? What have I diluted out? You got plenty of fluid? Your blood pressure through the roof. Girl, my cardiac output is good. Oxygen don't go where it don't say volume. It says what? And your hemoglobin and hematocrit is watered down. Oh yeah, girl, my blood pressure is great. And your SpO2 sucks. Don't just assume. Don't look at those numbers. Look at your patient. If they are in fluid volume overload, you've got a whole lot of problems. It might be affecting their heart. Now they're going to go into congestive heart failure. You're going to have pulmonary edema. What are you going to see? Pink, frothy sputum. It might not have got pink by this point. Guys, these people can go, and this is terrifying. I've seen it twice. Flash pulmonary edema. And like, I set him up. He was talking to me, and he was in volume overload for a whole month. And like he said, I can't breathe, and this stuff just starts flowing out of his mouth. We intubated him, and it's coming out the end of the tube. Severe hypertension. Breath sounds. What about my salt? It's going to go down. It's diluted out. What's the first sign and symptom of this and DI? Altered level of, did I say unresponsive? What's the earliest level of altered level of consciousness? Anxious. And kind of, just acting like, oh, I don't feel right. I feel like I'm going to die. Something. Altered level of consciousness. If we drop slow enough, seizures, headache, and evidently severe muscle cramps. What about their urine? How much urine are they making? None. This much. And it's not T-Rex this much, it's this much. So is it dilute or concentrated? Concentrated. Urine-specific gravity is high. How about your osmolality? It's low. How much stuff you got floating around? None. Because you have diluted your blood down. What are we going to do about it? We're going to leave all them fluid boluses going. Are you going to take diabetes out? No. Turn it off. Now, any patient, what goes into intake? PO, okay. Any fluids. Did I just say isotonic, hypertonic, hypertonic? What else goes in there? Medications. Even if it's a suppressor, guys, it's mixing what? Some sort of fluid. What about if it's hemorrhagic shock and you're administering blood? Every bag of, the next time y'all see a transfusion, go look at the bag. It'll have how many milliliters. Guys, that's intake of crystalloid or colloids. Colloids. Everything we put up here is what? We give crystalloids. What's albumin? Colloid. It's a lot of stuff. Every bag of fluid has a certain amount in it, and it's not the same. It's usually close like 325, 333. It's right around in that area. That is still intake. What is the ultimate goal? I need to decrease what? Water retention. And increase what? I need to increase sodium and manage. You do that by managing what? The hyponatremia. If I fix this, does that fix their urine? It does. You're treating the cause. Their concentrated urine is just kind of a after effect. What are you going to do? Hypervolemic. What are their vital signs going to look like? Hypertension. It's still going to, is this an insult to the system? I know there's not a hypervolemic shock, but still, it's an insult to the system. The body is in fight or flight. What's a high heart rate? Tachycardia. Hypertension. What's a high respiratory rate? Tachypnea, and also what will go along with that. Adventitious breath sounds, which one? Crackles. Stop all fluids. Like, we gonna monitor INO like it's your job. Daily weights, why? So, when you go to the doctor and you weigh, they might ask you what? Have you lost weight recently if they don't have trends, or if they like, dang, you lost some weight? Do we worry about this week if it's just a little? Usually you can lose like 1 pound a week and that's normal. What if you lost 10? That's going to get your attention. What if you gain 10? That's going to get your attention too, and you're going to see a whole lot of other signs and symptoms. I said this twice. Give sodium if needed. Now, where does the problem come in right here? Does that go away? It never goes away. Unless maybe it's a tumor and maybe you can get the tumor off. How compliant are they going to be? Because you're going to tell them you can drink 500 milliliters a day. And folks are going to be saying, okay! And they get home and what? They got out their Stanley, their Bubba Cup, and everything else. And patients are sneaky. Like if Sarah was my wife, the husband was sitting there, you can't drink that. He had silent aspiration, right? He had a stroke. Okay, girl, I come back in, he done took his wife's cup. And she's like, you don't need to drink that. I'm like, give me that cup. He knew it. Guys, you think about how bad that would be. Oh, you can drink half of that cup today and that's it. We all drink a little bit more than that. Patient compliance is a big deal with this. And is it just water? No. No orange juice, no milk, no nothing. Here again, they're going to do a CMP looking heavily at what? Sodium. What else you be in with creatinine? I'm not dehydrated. It might be what? It might be low. I've watered out my system. This is a big one. If you don't correct that sodium, they're going to die. If they start seizing and don't come out of it, what are your lungs? Smooth muscles. Where do seizures happen? Smooth muscles. What's the optimal smooth muscle contraction technique? They won't be breathing. That's why we worry about seizure patients. Doesn't matter why they're seizing. They've been seizing 20 minutes. Yeah. Absolute emergency.
You know, usually it ain't 20 minutes, it's like 2 seconds, and they thought it was 20 minutes.
You are going to have to tell them what? You've got to decrease your fluids. Why are they saying this? It gets their mouth a little bit wet. Guys, my aunt had lupus bad, and she had Sjogren's, which is what? It affects all the things, fluid, salivary glands, she made no tears. She made no saliva. Guys, what does saliva do? Helps you to break down food and helps you to taste food. She always kept water with her, and she would always keep hard candy. It does help, but it doesn't stop that. I want some water. You need to tell them what? When you need to call the doctor or when you need to come to the hospital, do you just need to tell the patient? If they're seizing, they can't say, hey, I need to go. You need to educate what? Their family or whoever's around them a lot. Tell them the signs and symptoms of hyponatremia. They're going to have decreased level of consciousness. They might be seizing, nausea and vomiting. I hope not. Unresponsive.
I have a question.
Yes, ma'am.
Are these people like on can they exercise regularly, or because exercise is gonna make them thirsty? So are they like on an exercise plan?
exercise in all facets help, but we might have to work. If we go exercise together, and the person showing us the exercises, they gonna say what? Or she needs to, huh? We need a modifier for her. She ain't doing the full push-up. She gonna do the knee push-ups, or we might just do this much. Guys, can this be life altering? They might have been a marathon runner before, and they got a traumatic brain injury, and they can not just now. You can control it a lot better. Hey, you're never gonna run another marathon, and they might get mad, and they can say, "I'm gonna do whatever I want to," and then you wind right back up in the hospital. I'm not gonna tell you no, but you definitely would have to modify it. And you definitely would have to tell them, these are the signs and symptoms. Initially, how close do you think their physicians are going to be monitoring them? Very. What kind of doctor is going to see them? Endocrinologist. Y'all need to take a quick break before we talk about solid sex and sugar.